Next is Bhushan Shetty, comparison of 99m technetium DTPA renal dynamic imaging with Mayo quadratic Cockcroft Galt MDRD and CKD EPI formulae for estimation of GFR among both South India.
Good morning. I'm Dr. Aditya Shetty. I'm presenting on behalf of Dr. Bhushan Shetty, who was not able to make it here today. So this study of his was done, is titled A Study of Comparison of 99 Technetium DTPA Renal Dynamic Imaging with Mayo Quadratic Equation, Cockcroft-Gault, MDRD and CKDPA formulas for estimation of glomerular filtration rate among South Indian live-related kidney donors. So GFR is an important filtering indicator of filtering capacity of the kidney and is overall the best index of renal function. Estimated GFR is most important variable in the assessment of patients with suspected or known kidney disease in clinical practice. Traditional methods using renal clearances like inulin or other alternative markers can provide accurate GFR measurement, but are time-consuming and expensive and not practical in all individuals. To monitor kidney function periodically, GFR estimating equations has been recommended in clinical practice since 1976. DTPA renal dynamic imaging method where GFR is calculated simultaneously using a computer system when the patient is undergoing dynamic imaging. Radionuclide 99 technetium DTPA is widely used because it is filtered without tubular reabsorption. In this study, we compared DTPA dynamic imaging with that of estimated GFR by Mayo quadratic equation, Cockcroft-Gault versus MDRD versus CKDPA in the South Indian live donor cohort. So the objectives of the study was to study the correlation of measured GFR to estimated GFR via various equations and to analyze how closely the GFR calculated by these formulae correlate with the DTPA renal scan. It is a retrospective observational study conducted at Institute of Nephrology, Bangalore, in between from January 2013 to October of 2022. All voluntary living donors in this time span were included in the study, and donors with relevant data missing to calculate the estimated GFR were excluded from the study, and those with other comorbidities. So downloadable calculators were used. MDRD 4-variable equation was used, and Cockcroft-Gault equation, we adjusted the body surface area to convert the creatinine clearance into estimated GFR. Results were analyzed using descriptive analysis was used, and following which correlation was made by calculating Pearson's correlation and student t-test for comparison of p-values which were considered significant. And to confirm this correlation, weighted kappa agreement was used. So our subset of patients, totally 151 patients were included. 75% of the donors were women and 25% of the donors were men. Age distribution, most of our patients were between 45 to 54 years age group, followed by those between 35 to 44 years. So comparison of measured GFR by DTPA with that of estimated GFR by the various equations by dependent t-test. Here you can see first yellow band is that of GFR by MDRD formula, and the row above that will be the GFR measured by DTPA. So mean variation, we can see that that with MDRD is 100 versus 105 measured by DTPA. CKDPA has a closest correlation, which is 102 GFR as opposed to 105 by DTPA. Mayo quadratic equation overestimates, where mean GFR was 109 as opposed to measured GFR of 105, and Cockcroft-Gault underestimates with the GFR of 97 as opposed to DTPA measured 105. In this, significant is all are statistically significant, p-value of less than 0.05. But the strength of association here was more with Cockcroft-Gault, where t-value was 4.78, which was the highest amongst these. This is comparison. When we go on to correlation between the GFR by DTPA versus the estimated GFR, we see that GFR by CKDPA formula, which is in the row, and as compared to GFR by DTPA, we see that the R value of correlation coefficient is the highest for CKDPA formula, which is 0.53. So the strength of correlation of these differences is highest with CKDPA, and CKDPA had the most proximity to measured DTPA also. So to confirm this correlation via Carlson-Pearson correlation equation, weighted kappa agreement was used. And even in this, we can see that measurement of GFR by CKD-EPA has the highest agreement, 82.9%, as compared to measurement via other methods. And all these variables are statistically significant. So to conclude, the evaluation of GFR is central to the assessment of kidney function in medical practice. Measured GFR remains the standard overall. But because it's not feasible, we are comparing in our set of population what is the correlation of estimated versus measured GFR. So most of our patients, 75% of the living donors were women during this time period, and 45 to 54 years was the most common subset of donors. The mean of measured GFR in our study was higher, 105.64 ml per minute, where it was approximately 98 in another study done in India. So ours is the first study in this regard where we studied the comparison and correlation between these four formulas versus measured GFR by DTPA. So upon application of Carlson-Pearson correlation coefficient and weighted kappa agreement, CKD-EPA equation performed better in terms of accuracy as well as precision when compared to others. And similar observations were noted in other studies as well, where CKD-EPA correlated better to measured GFR. So to conclude, we found that CKD-EPA GFR performed better in terms of precision as well as correlation when compared to other formulas in South Indian subset of living donors. So CKD-EPA is suited to identify subnormal GFR in clinical practice and in epidemiological studies in our population. Thank you.
This was just an observational study, isn't it?
Yes,
retrospective, and you took all the things.
Yes, ma'am.
What was the least GFR and what was the highest GFR of your donors?
I'll have to go into that, ma'am, because I'm not sure about that data.
Because these tests, no, they are not equally going to tell when there is a relatively lower GFR. What is the least GFR that you can take as a donor? What is your policy?
In our hospital, normal renal functions are only taken up. Diabetics, other comorbidities are not taken up. So GFR at least 90 we take the cutoff in our center.
90 only you're taking as a cutoff?
Yes.
I think that's a little too much.
Were you surprised by the result? Because we all probably knew that CKD-EPI will be a standard closest to DTPA.
No, ma'am. This was more of confirmation of the previous studies. That's all. We didn't find anything out of the ordinary in this.
And Cockcroft actually, it's sometimes overestimates. So how did you get a value where it underestimates and also its p-value was significant?
Probably most of our donors were females. So in Indian subset, I think that would have added up for the lower GFR, lower muscle mass in our subset of patients.
Thank you.
Thank you.
Any other questions from the floor?
Usually for the donation of the kidney, we need individual GFR. So in what way this is going to help us?
Sir, more than donors, this showed that there is a good correlation between CKD-EPA and DTPA in our normal people, individuals with normal renal function mainly. So rather than this study in helping with regards to live donor screening, for general public, we see that there is correlation between measured versus estimated GFR.